Good morning, good afternoon, good evening, whichever time you are watching this presentation. My name is Chrissy Tabulov and I'm currently an assistant professor at the University of South Florida Tunisia College of Pharmacy in Tampa, Florida. My clinical practice site is in pediatric nephrology at Tampa General Hospital. Today I'll be presenting on pediatric hypertension as part of the Pediatric Pharmacy Association Pediatric Competency Series. The objectives for this presentation include building the foundational knowledge of pediatric hypertension by describing the etiology and pathophysiology. I would also like for you to be able to explain the different stages of pediatric hypertension and how to proceed with management of the hypertension at various stages. I would also like for you to utilize data to determine appropriate percentiles to classify the hypertension that a pediatric patient may present with, then finally describe management approaches for a pediatric hypertension patient. I have nothing to disclose. So let's start by providing an overview of pediatric hypertension. The overall incidence of pediatric hypertension is between 1 and 5% of the pediatric population as a whole. Thinking about this number in comparison to our adult population, this number is much smaller compared to our adult population with about 28% having hypertension. When a pediatric patient is diagnosed with hypertension, there is an association of seeing increased incidence of hypertension in adulthood. Hypertension overall has two different etiologies, primary and secondary. Primary hypertension is described for you on the left-hand side of the slide. This is the hypertension that you may remember most likely from pharmacy school. Primary hypertension is hypertension that presents without a known cause, and this type of hypertension is associated with the name of the silent killer. This type of hypertension you can see more commonly in the adult population. However, primary hypertension's incidence in the pediatric population is rising, especially in the older children and adolescent populations. The other type of hypertension is secondary hypertension, as you can see in the green box on the right-hand side of the slide. Secondary hypertension is hypertension that is linked to a direct cause. Common etiology seen in the pediatric population for secondary hypertension include renal and neurological diseases, as well as coarctation of the aorta. Secondary hypertension is seen more commonly in pediatrics. In the next slide, I will review causes of hypertension in more detail by age group. This table on this slide breaks down the various etiologies of hypertension by age group. The etiologies listed in the first column, some of these terms you may have never heard of, and I will go through a brief description of these with the subsequent columns listing the age group. Starting with neonates, common etiologies found are renal artery thrombosis and venous thrombosis, renal dysplasia, which means the internal structures of one or both of the kidneys are not developed normally, polycystic kidney disease, which is an inherited disorder that leads to cyst development and causes the kidney to get larger and lose function over time, obstructive uropathy, which is when there is obstruction that does not allow the urine to get through the urinary tract. Neoplasia is another one, which is essentially an uncontrolled growth that occurs in the kidney. So essentially thinking of a tumor being in the kidney. Coarctation of the aorta, as mentioned before, essentially narrowing of the aorta, which makes it difficult to pump out blood to the rest of the body, and hyperthyroidism. You could imagine with these various etiologies that there's a buildup of pressure or volume that can result in a secondary cause of high blood pressure. Next, we have our infant to 6 years of age group, which has similar etiologies minus a few. Additional causes in this age group include pyelonephritis, glomerulonephritis, which is essentially inflammation of the glomerulus, which is the portion of your kidney that filters out toxins, metabolic waste, and fluid. And also you can see hypertension associated with end-stage renal disease. These causes, again, are more linked to a secondary cause of hypertension. Then we have the 6 to 10 year age group and has less etiologies of secondary hypertension, including renal artery stenosis, which is essentially narrowing of that renal artery, pyelonephritis, glomerulonephritis, and end-stage renal disease. This is where you commonly start to see essential hypertension or primary hypertension be seen in the lifespan. And then you move on to 10 years of age through adolescence, and you can see that there's similar etiologies to the 6 to 10 year age group without as high of an incidence of renal artery stenosis. So moving on now to pathophysiology. When we think about pathophysiology of pediatric hypertension, there are two different mechanisms to remember. The first one being neuroregulation, which involves the central nervous system focusing on sympathetic tone, the baroreflex system, and cardiopulmonary reflex. In addition, humoral regulation can occur through the renin-angiotensin-aldosterone system, commonly known as the RAS system. There are also endothelial vasoactive factors, glucocorticoids, arginine vasopressin, and natriuretic peptides. One thing to note is that there's not a single pathway that has been associated being the only cause of pediatric hypertension. So this is why we have multiple drug classes that target different portions of these pathways. And we'll discuss these two major pathways in more detail on the next slide. So here is a picture that displays how neural and humoral regulation occurs for hypertension. So starting with neural regulation, this is accomplished through the central nervous system, starting with the brain. There are different receptors throughout the body that help the nervous system regulate blood pressure. First, we have alpha-1 receptors in the peripheral blood vessels. When activated, vasoconstriction occurs, which can increase blood pressure. There are also beta-1 receptors present in the heart that can lead to increased heart rate when activated, which can increase blood pressure as well. In addition to these various receptors, there are also baroreceptors that regulate blood pressure in the brain, in the carotid arteries, as well as the heart. These baroreceptors work when it is sensed that blood pressure has decreased. The baroreceptors will be kicked into gear to work to increase blood pressure. This system works in conjunction with humoral regulation within the kidney, involving more specifically, again, that RAS system, as most of us may know it as. The therapies we will discuss later in this presentation will target a certain area of one of these pathways. So let us go ahead and pause to review a question. Which of the following is a common cause of primary hypertension? Is it A, polycystic kidney disease, B, coarctation of the aorta, C, pyelonephritis, or D, unknown cause? I'll go ahead and give it a few seconds. If you need more time, please feel free to pause the video. And the correct answer is D, unknown cause. When going back to that etiology slide, we discussed primary hypertension as being that silent killer with no known cause. Although we don't see primary hypertension in the pediatric population as often, it is important to remember its incidence is rising. The other answer choices are more associated with that secondary hypertension picture. All right, now that we reviewed hypertension, etiology, and pathophysiology, let us go ahead and discuss how do we go about interpreting blood pressure in pediatric patients. Fortunately, there are hypertension guidelines published by the American Academy of Pediatrics, commonly known as the AAP, that discuss how to interpret blood pressure values in children, diagnosing and treatment recommendations. There are blood pressure tables in the guidelines that are based on a normative distribution of healthy children, which is illustrated for you in the graph on the right-handed side of the slide. The blood pressure values are interpreted based on the sex of the child, so male or female, the age of the child, as well as height. Keep in mind that these tables are not reflective of obese children. It is thought that the obese children would create bias as obesity and hypertension go hand in hand. The black line below the green section of the graph to the right-hand side is the median, which is the 50th percentile. In this 50th percentile line, up through the 90th percentile is considered normal blood pressure for a child. We will go into more detail on pre-hypertension and hypertension on the next slide. So here's a table that discusses blood pressure categories, which is divided by the columns children age 1 to 13 years of age and children 13 years of age and older. We already discussed normal blood pressure on the previous slide for younger children, but keeping in mind once adolescence is reached, adult values such as less than 120 over less than 80 millimeters of mercury would be the cutoff. Elevated blood pressure is between that 90th and 95th percentile, or 120 over 80 millimeters of mercury to less than 95th percentile, whichever is lower between these two cutoffs. Stage 1 hypertension is between the 95th percentile to less than the 95th percentile plus 12 millimeters of mercury, or similar to the adolescents, whichever is lower. Followed by stage 2 hypertension, which is greater than that cutoff or greater than 140 over 90 millimeters of mercury, whichever is lower. When evaluating blood pressure to classify a child's blood pressure, the guidelines discuss ensuring the child is seated correctly, using either auscultation, which is manual blood pressure, or an automatic blood pressure cuff to measure blood pressure. The blood pressure should be measured twice if greater than the 90th percentile to get an average of the two blood pressures. If the average is greater, it is recommended to use manual blood pressure technique to ensure this is accurate if an automated way of assessing the blood pressure was used before. If blood pressure is greater than or equal to the 90th percentile, you would go ahead and classify according to the tables. So you're probably wondering, what on earth do these blood pressure tables look like? So let's go through an example. You have a 4-year-old boy in your clinic who is 40.5 inches and has a blood pressure of 104 over 62. So I would go about looking at this blood pressure table that is in the guidelines. So first and foremost, being able to identify the different blood pressure tables. So just to let you know, there are tables for boys as well as girls. So making sure that you have the boy table selected, because since it's based on height and weight, that can fluctuate between boys and girls. Next, I go ahead and locate the age of the patient. So because I have a 4-year-old, the first column depicts age in years, so I go down to the 4. Then next, I think about my blood pressure value. So I go ahead and start looking at the systolic blood pressure column. I have a height that I can use to start guiding where I'm going to look. So these blood pressure tables are adjusted based off of the height percentile or measured height. And since I know my patient's height is 40.5 inches, I'm going to look at this column that's highlighted in red. And then I pull the systolic blood pressure. I have 104. So 104 is considered the 90th percentile at this point. Then I move on to the diastolic blood pressure. And because I have a patient who's 40.5 inches, the diastolic is going to be 62. So as you can see, both values are going to be that 90th percentile. So I can determine that our patient here has a blood pressure of 104 over 62, which is considered the 90th percentile. I also wanted to go through briefly what neonatal hypertension looks like. So it's not the focus of the presentation, but I would like for you to be aware. Again, this is the table continuing with more premature post-conceptual ages as you go down, and you can see that same trend on this slide. Now that we have reviewed how to categorize blood pressure, let's pause for a quick question. KS is a 7-year-old female who is currently admitted on the general pediatrics floor. She has a height of 121.1 centimeters and a blood pressure of 127/87. Which percentile would you categorize her blood pressure? Is it A, 50th percentile, B, 90th percentile, C, 95th percentile, or D, 95th plus 12 millimeters of mercury percentile? I would highly encourage you to pause this video and pull up the AAP hypertension guidelines and go to the appropriate table. That way you are able to practice your response. I'll go ahead and give a few seconds, or you can pause the video. The correct answer is D, 95th plus 12 millimeters of mercury percentile. Let us review on how we found that answer. Alright, so hopefully you have table 5 in the guidelines pulled up. Again, making sure that you have the right sex of the patient pulled up. So because we have a female, we are looking at the blood pressure levels for girls by age and height percentile. Because we have a 7-year-old patient, we're going to go ahead and go down to that 7 years of age row. Now, thinking about the systolic blood pressure of the patient, we have a height of 121.1 centimeters. Because the systolic is 127, we're going to go ahead and pick 123, which is that 95th plus 12 millimeters of mercury percentile. But we also need to look at the diastolic blood pressure, because again, we have 121 centimeters as the height for the patient. We have a systolic blood pressure of 87. We can pick the 85 as the height percentile. So we will go ahead and classify this patient as having a blood pressure percentile as 95th plus 12 millimeters of mercury. Expanding upon the classification of hypertension previously discussed, one can see that for normal blood pressure monitoring is done routinely at office visits, generally once a year. Of course, healthy lifestyle choices are encouraged and no pharmacologic therapy is recommended. For pre-hypertension, it is recommended to check in 6 months. If the patient is overweight, it is recommended to address the weight through diet and exercise. No pharmacologic therapy is recommended unless there are comorbidities present, such as chronic kidney disease, diabetes, heart failure, or left ventricular hypertrophy. Stage 1 hypertension is when you see pharmacologic therapy being initiated and blood pressure is rechecked in 1 to 2 weeks or sooner if symptomatic. Stage 2 hypertension, pharmacologic therapy is also recommended and you start to have more specialist involvement. Before we go into management of pediatric hypertension, let us review other indications to start antihypertensives. This includes hypertension that is still occurring despite lifestyle modifications, hypertension that is symptomatic, stage 2 hypertension without a modifiable risk factor, hypertension that is related to diabetes or chronic kidney disease. Now let us discuss management of pediatric hypertension. As displayed in the table from a couple slides ago, it is recommended to incorporate lifestyle modifications and add pharmacologic therapy once a patient is diagnosed with stage 1 hypertension generally. Lifestyle modifications include exercise, weight loss, and stress reduction. Exercise can be used as a primary or adjunctive treatment. It is recommended by the American Heart Association for children at least 2 years of age participate in moderate intensity physical activity each day of the week. Weight loss is beneficial as weight loss can result in decreased blood pressure, decreased development of high cholesterol, and prevent insulin resistance. Of course, encouraging salt restriction within the child's diet as well. Stress reduction is also helpful in reducing blood pressure, and it's also an area to look more as an potential intervention. You may also be familiar with the DASH diet, which is a diet discussed in the literature to lower hypertension. You might have remember seeing as part of your pharmacy school hypertension lecture for the adult population. You can also use it in the pediatric population as appropriate. Of course, the DASH diet, just to remind you, means dietary approaches to stop hypertension. The general trend with this diet is to incorporate more fruits and vegetables as well as whole grains while minimizing food that's high in fat, sugar, and salt that could work to potentially increase that blood pressure. Now switching gears from lifestyle modifications to pharmacologic therapy. These drug classes are similar to what you may be familiar with in the adult population. These drug classes include angiotensin converting enzyme or ACE inhibitors, angiotensin II receptor blockers or ARBs for short, thiazide diuretics, as well as calcium channel blockers. First up, we have ACE inhibitors. So essentially, they work by inhibiting angiotensin 1 to angiotensin 2 working at that ACE enzyme, ultimately resulting in decreased systemic vascular resistance to drop blood pressure and prolonging the half-life of the bradykinin vasodilator by inhibiting its metabolism. These tables are meant only as a summary and have been compressed for formatting. These tables should not be used for clinical practice, but I would like to provide you an overview of the different agents available, listing the different drugs, the age groups they're generally used in, initial dosing, how frequently we give these different agents, the maximum doses, as well as the dosage forms that are available. So just to highlight a few of the ones that are seen most commonly in practice, so at least what I have seen, captopril and lisinopril are the two that I have seen most often. Captopril, it's used in the younger patient populations as well. So you can see infants and children listed. You can see the interval. You can go up to 3 times a day dosing or 4 times a day dosing. What is nice about captopril, it's easily titratable, so you can quickly make dose adjustments or at least titrate, more slowly in case you are concerned for hypotension in a younger patient. Lisinopril, it's recommended generally in children who are at least 6 years of age. However, children less than 6 years of age does have some limited data that recommends a similar dosing as well. So I have seen lisinopril used in younger patients less than 6 years of age as well. And then other dosing I wanted to bring up is ramipril. So ramipril dosing has been described by Seaman and colleagues in the literature. They recommend starting a dose of 1.5 milligram per meter squared per day. And this was in patients with hypertension and or proteinuria. This study included patients who were around 2 years of age up through 19 years of age, and anecdotal evidence does suggest that the ramipril capsule may be opened and dissolved in water or placed directly in the mouth or on bread. But from what I've read, the capsule does not taste good, so its utilization may be limited in our patient population. I have also listed in the dosage forms column extemporaneous liquid. That means compounding is involved. I would like for you to defer to your institutions to see how the compounding process is for these various medications. As far as adverse effects of ACE inhibitors go, so very similar to the adult population, you can see headache, cough, dizziness, asthenia. Severe would be acute kidney injury, elevated potassium, fetal toxicity, and angioedema. It's contraindicated in patients who have had experienced angioedema in the past, as well as pregnant patients. Some things to note are you can see increased incidence of hypotension with the use of ACE inhibitors in neonates and infants. And you can also see more hyperkalemia, or those elevated potassium levels, occur in the pediatric population compared to the adult population. As far as other population differences, the heart failure data is extrapolated from adults. Although the focus of today's presentation is on hypertension, I just wanted to let you guys know about that. And then neonates and infants may require lower initial dosing, so it might be better to start low and go slow until you find what works best therapeutically. And also, the incidence of cough is lower in the pediatric population compared to adults. As far as pediatric administration considerations, like I mentioned before, captopril has more frequent dosing, but it's easily titrated, so you can make changes as necessary more quickly. And then also, thankfully, as we saw in the previous slide, there are ACE inhibitors that do have commercially available liquids as well. So just pull up your drug information resource and work with, outpatient pharmacies in your area to make sure that you're able to get that commercially available product. The next drug class is angiotensin receptor blockers. So again, this mechanism of action essentially is blocking the binding of angiotensin 2 to that angiotensin 2 receptor to work to lower blood pressure. As you can see, there are different medications in this class, with different age groups and weight cutoffs. There's initial dosing, differences with the interval. So most of these agents are going to be daily dosing. Maximum doses are also listed for you, as well as available dosage forms. So you can see that first drug, candesartan, generally used in a variety of age groups. However, for adolescents who are at least 17 years of age, there are recommendations to start at that higher dose of 16 milligrams per day, just making sure that you're looking closely at those age cutoffs as well as weight cutoffs as you see those initial dosing recommendations change. Irbesartan, it comes as a tablet. You might think that there's restrictions in the pediatric population. However, you are able to crush and dissolve the tablet with, 5 to 10 mLs of water, however you feel the child would be able to swallow easier with. And then olmesartan has limited data in children under age 6, and at least 5 kilograms. There are dosing recommendations of 0.3 mg per kg per dose once daily, and that can be increased after 2 weeks to 0.6 mg per kg per dose once daily. And of course, watching for the initial dosing caps as well as maximum dosing caps to make sure that you're not over the recommended dosing. As far as adverse effects of our ARBs, common side effects include headache and dizziness. You can also see more severe adverse effects with acute kidney injury, hyperkalemia, and fetal toxicity. Similar to ACE inhibitors, it's going to be contraindicated in pregnant patients. Angiotensin receptor blockers may not be used as widely as ACE inhibitors in pediatric patients because the data in children less than 6 years of age is limited. However, more data keeps coming out slowly, so just make sure that you stay up to date on that. And incidence of cough is low. Similar to the adult management of hypertension, you may switch to an ARB from an ACE if a patient is experiencing cough, because it doesn't affect the bradykinin as much. Pediatric administration considerations, so generally not recommended with a creatinine clearance less than or equal to 30 mLs per minute. Valsartan is not recommended in children less than 6 years of age. Valsartan suspension, just keeping in mind, has higher bioavailability compared to the tablet. So considering when you have patients who were on the suspension and they don't need liquids anymore to take their medications and they're willing to start a tablet, you may want to consider decreasing the dose to the lower tablet size that's available, just to make sure that you are not going to bottom out their blood pressure, as the tablet and the suspension are not bioequivalent on a milligram to milligram basis. Excuse me. Once daily is not effective, you can consider splitting the dose and giving the ARB twice a day if needed. So those are just some pearls to consider when using ARBs in the pediatric. Next, moving on to thiazide diuretics. So essentially, thiazides work in that nephron in that distal tubule, so inhibiting the sodium potassium chloride transporter. And there's mild diuresis, inhibits about 5% of total sodium absorption. So again, you can see the different drugs listed: chlorthalidone, chlorothiazide, and hydrochlorothiazide. You've probably seen the chlorothiazide and hydrochlorothiazide used more commonly in the pediatric population. And similar to the previous slides, you see initial dosing, the interval, with most of the time being daily. Sometimes you do have to use twice a day dosing, and then also review dosage forms. So chlorthalidone is up and coming in the pediatric population, available as a tablet. However, you can crush chlorthalidone if needed. Crush and dissolve in 5 or 10 mLs of water, depending on how the patient would be with those different volumes. So chlorothiazide, we're focusing mostly on oral dosage forms, with it being outpatient management. However, you probably have seen it in the inpatient setting with the IV version, and just remember that dosing conversion from PO to IV is not 1-to-1. Remember that IV dose does need to be doubled for the oral dose to achieve similar efficacy. The hydrochlorothiazide dosing, you'll see more and more. There's been different drug shortages over the last couple of years, and the infants and children, in the AAP guidelines, the max dose is described as 37.5 milligrams per day. However, there is dosing that's discussed up to 50 milligrams in the adolescent population. However, there is discussion on the adult side that there may not be additional efficacy beyond 25 milligrams. So just make sure with your patient, if you're above that 25 or 37.5 milligram dose, just making sure that you're make sure that it's efficacious as well as safe for your patient. And also remember that 10 milligrams of PO chlorothiazide is equal to 1 milligram of PO hydrochlorothiazide. So even though it's a similar drug, they are not dose equivalent. As far as adverse effects of thiazide diuretics, common adverse effects are hypokalemia and dizziness. More severe adverse effects, you can see pancreatitis. You can see diabetes emerge from use of thiazide diuretics. You can potentially see dysrhythmias, likely resulting from electrolyte abnormalities, as well as cholestatic jaundice. As far as population differences, we really don't know why patients may develop increased blood sugars as well as increased lipid levels. And there's limited pediatric data with loop and thiazide diuretic synergy. However, I can say that I've seen it used in my practice as part of the nephrology group, but more data is needed to support it compared to the adult population, where there's more robust data. And just keeping in mind with thiazide diuretics, we want to avoid them in the renal impairment population as much as we can, as they're most likely going to be ineffective. Now moving on to calcium channel blockers. So calcium channel blockers work again by blocking extracellular calcium influx to prevent cardiac and vascular smooth muscle contraction. So there's the dihydropyridines, or DHPs, and the non-dihydropyridines, non-DHPs, similar medications that are used in the adult population. And you can see different age dosing, initial and maximum doses. Most of the time, these DHPs are going to be given daily. Isradipine, you give more frequently, BID to TID dosing, with the extended release being daily, and there's different dosage forms. The non-DHPs, nifedipine, you can see is daily to twice a day. Adverse effects of calcium channel blockers are peripheral edema, flushing, and dizziness. You can also see angioedema occur as well. Population considerations, so non-DHPs aren't recommended in children less than a year of age because of increased risk of fatality. And children under 6 years of age may require higher doses per kilogram for adequate blood pressure control. I can also note, just looking at case reports, a lot of times patients on my service in the nephrology group are started on amlodipine, and sometimes they get gingival hyperplasia from it, and there's some case reports that suggest changing from amlodipine to isradipine can help decrease the gingival hyperplasia as well. I have seen that get accomplished in practice. However, there's more data that is needed to support that practice, but just a little pearl if you encounter that in your practice as well. And what's nice is other considerations in the pediatric population. Amlodipine is just once a day dosing. And just remember your extended release formulations, they're not able to be crushed or chewed. So if your patients need help with swallowing these medications, you'll likely need to consider switching to an alternative medication. All right, let's pause here now that we've reviewed our first line agents and answer our third question. So, which of the following is the best rationale for the use of valsartan suspension for an 8-year-old female patient? Is it A, poor palatability, B, high oral bioavailability, C, more frequent dosing, or D, there's no suspension available? The correct answer is B, high oral bioavailability. As described when we were discussing angiotensin receptor blockers, valsartan suspension has higher bioavailability compared to the tablet. Poor palatability is incorrect, although may happen for some patients because as a pharmacist who cares for the pediatric population, we need to keep in mind that medications should taste good to help with adherence. More frequent dosing is not a rationale for valsartan use, as valsartan is commonly used as once daily dosing for chronic hypertension management. And finally, there is a suspension available for valsartan. Another reminder that the valsartan tablet and suspension are not bioequivalent, as the suspension has higher bioavailability. So when switching from a suspension to tablet, a higher dose may be warranted. Alternative pediatric hypertension agents include beta blockers, peripheral alpha blockers, central alpha antagonists, other classes of diuretics, including loop and potassium sparing, and finally vasodilators. Next up, we have beta blockers. Beta blockers work by decreasing the inotropy and chronotropy, ultimately reducing heart rate, which ultimately works to decrease cardiac output. There's 4 different beta blockers: atenolol, metoprolol, propranolol, and labetalol that have been described in the pediatric population. Propranolol and labetalol are, of course, your non-selective beta blockers. You can see the interval varies from daily up through 4 times a day, so you can get propranolol more frequently. So just paying close attention to your dosing resource, and you can see that these different agents are available in liquid formulations. Just to review some adverse effects of beta blockers, you can see lower heart rates, bronchospasm, drowsiness, fatigue, and more serious cases, you can see heart block occur. Of course, being cautious in patients with asthma. If you do have an asthmatic and you need to use a beta blocker and can't use an alternative drug class, ensuring the beta blocker is more cardioselective, such as metoprolol. And of course, being cautious in patients who are diabetic, since beta blockers may mask signs and symptoms of hypoglycemia. And just some considerations with beta blockers: propranolol is the most lipophilic, so you can see a higher risk of nervous system adverse effects. And atenolol does have a higher risk of accumulation in patients who have renal dysfunction. Next, we have peripheral alpha blockers. They work by acting at the alpha 1 receptor and selectively blocking this receptor to ultimately have vasodilation occur. These medications are not used as commonly in the pediatric population, but I included information about them for completeness. Next, we have the central alpha agonists. These work by being selective towards the alpha 2 receptor and ultimately resulting in reduction of that sympathetic tone, so working to decrease that blood pressure. There are 3 different agents: clonidine, guanfacine, and methyldopa. Clonidine is the agent that I've seen most commonly used in practice. Just making sure you're paying close attention to the units for the different dosages, and you can see that these agents come in a variety of dosage forms. So for central alpha agonists, you can see adverse effects such as bradycardia, constipation, drowsiness, dry mouth, sedation. You can also see orthostatic hypotension and rebound hypertension. Again, thinking about the utilization in adults, it's pretty low, and often this gets translated to pediatrics. You will generally see, if it is used in the pediatric population, in patients with ADHD and hypertension, as it can be thought that it could target both of those disease states. I also see it quite a bit on my service, as if you think about the first line agents, I may not be able to use ACEs and ARBs or thiazide diuretics, which really limits what agents I can use if my patient is not having their blood pressure be fully controlled by a calcium channel blocker. And if you do have patients who are using a transdermal dose, that's going to be equal to their total daily dose. So that's a consideration that's important when you are switching from, the patch to oral. You can convert the dosing that way. Of course, if you do have a patch being used, making sure that you don't cut it. And again, with clonidine, paying very close attention to your units, so that microgram versus milligram. And then also just making sure that you don't have the patient discontinue abruptly because of that rebound hypertension that can occur. Next, we have the loop diuretics. So loop diuretics work by inhibiting the sodium, potassium, and chloride transporter in the ascending loop of Henle, ultimately promoting diuresis and large amounts of sodium excretion. So the one that we commonly see is furosemide. That can be dosed anywhere from daily up to 4 times a day. Comes as a tablet in a solution. Just keeping in mind that you can see a higher risk of ototoxicity when you have higher doses be used, and there is bumetanide and torsemide as well, however not routinely used for hypertension management. Next, we have the potassium sparing diuretics. So these agents work by promoting diuresis while conserving potassium, and you can see the different agents listed below. Spironolactone is the agent that I most commonly see. You can see the initial dosing as well as the maximum dose. Generally, these agents are given daily or twice a day. The spironolactone is available in a suspension and tablet. Of course, trying to avoid use in patients who have renal impairment, and also just being cautious when handling, as these agents are considered a hazardous agent per USP 800. And then last but not least, vasodilators. So vasodilators work, of course, by promoting vasodilation in the periphery and hoping to decrease blood pressure. Hydralazine is one of the common agents used. You can see it can be given up to 4 times a day. Just watching your maximum doses, it comes as a tablet. And then you can also see minoxidil as well with the dosing list. And minoxidil is generally reserved for more refractory hypertension after several agents have been tried, just because of its side effect profile. It can cause a lot of hair growth, so we really try hard to avoid those cosmetic effects when possible. All right, so question number 4. Which of the following medications is available as a transdermal patch to help increase compliance of a pediatric hypertension regimen? Is it A, clonidine, B, hydralazine, C, labetalol, or D, spironolactone? The correct answer is A, clonidine. So again, clonidine is available as a transdermal patch. The other agents currently are not available as a transdermal patch. And then let's go ahead and review the pharmacologic agents that can increase blood pressure. Of course, we have over-the-counter drugs such as decongestants. So a lot of times I think about pseudoephedrine that's available behind the counter, caffeine, of course, as well. So, if someone is diagnosed with hypertension, we want to discourage the use of caffeine pills and also limiting caffeine consumption as part of the diet. Non-steroidal anti-inflammatory drugs, so trying to avoid ibuprofen or naproxen if possible, and then also avoiding alternative and herbal supplements. Some of these include ephedra, bitter orange. There's different agents that are reported in the literature. You can also use natural medicines as a great tool to remind yourself, if there's a certain herbal supplement that may cause hypertension. Prescription drugs, keeping in mind stimulants that are used for ADHD, such as methylphenidate and amphetamine, hormonal contraceptives, especially those with estrogen, steroids, and tricyclic antidepressants as well. And then, of course, encouraging the avoidance of illicit drugs, so cocaine can increase blood pressure, as well as amphetamines that are being using recreationally as well. I did just want to go ahead and touch upon a study that was found in the literature by Kilber and colleagues that was published in Pediatrics back in 2016. So this was a retrospective cohort study that looked at patients from 3 to 18 years of age and seeing the diagnosis and initial medication management of pediatric hypertension and prehypertension in the primary care setting. This study had an average time period of around 62 months, which ranged from 4 months all the way to about 14 years. Included around 400,000 patients, and overall it found, that hypertension and prehypertension are not diagnosed frequently, and that goes back to what we were describing in the incidence slide at the beginning of this presentation. About 6% of patients were prescribed antihypertensives within a year of diagnosis, and you can see what was commonly prescribed was the ACE inhibitors and the ARBs at 35%, followed by diuretics. You also saw calcium channel blockers, and then of course the least frequent being the beta blockers. All right, before we wrap up the presentation, let's go ahead and have one last question. So which of the following medications is not considered a first-line agent for a 14-year-old patient diagnosed with stage 1 hypertension? Is it A, lisinopril, B, losartan, C, clonidine, or D, amlodipine? The correct answer is C, clonidine. So the alpha-2 agonists are not considered a first-line agent. Lisinopril is an ACE inhibitor, which is a first-line agent for hypertension. Losartan is a ARB, which is also considered a first-line agent, and then amlodipine is a calcium channel blocker, so another first-line agent. All right, I want to close out this presentation by providing some key concepts. So hopefully you remember that pediatric hypertension is more commonly associated with secondary causes of hypertension compared to that primary hypertension, which doesn't have a known cause for the hypertension. But remember that primary hypertension is on a rise. Pediatric hypertension is based on age, gender, and height. And when we treat pediatric hypertension, we really want to encourage lifestyle changes if possible. And then once that patient hits stage 1 hypertension, that's when the pharmacologic therapy gets introduced. And also remember your first line agents in pediatric population are going to be similar to the adult population. So those ACE inhibitors, the ARBs, thiazide diuretics, as well as calcium channel blockers. And here are my references. And thank you very much for your attention during this presentation. I hope you were able to learn more about pediatric hypertension. I hope you have a great day.